Than the master here, Dr. Sushil Chauhan, who is going to talk on calcium, 18 to 80. I'm not sure what it means 18. Does it mean 18 days or does it mean 18 years? He'll elaborate on that today. I look forward to a masterly presentation by Dr. Sushil Chauhan.
Thank you, Dr. Tulsi sir. It's a topic. भाई माइक है? आवाज क्यों नहीं आ रही? Okay, so it's a topic which would interest everyone, from pediatricians to gynecologists to physicians to super specialists to diabetologists like Dr. Sen Gupta sir. And I would I request all of you to please keep decorum during the talk. It's a very small talk, but a very relevant talk for all of us. ये लाइट बंद करवा दो पीछे से यार, लाइट नजर नहीं आएगी, फायदा क्या है? एक और फायदा लाइट बंद करने का, किसी को समझ में नहीं आएगा कौन क्या पी रहा है। अब डॉक्टर प्रदीप गुप्ता बैठे चुपचाप बेचारे पानी पी रहे, डॉक्टर सेन गुप्ता मजे ले रहे धीरे धीरे, डॉक्टर संजीव सचदेवा मैडम से कुछ मजाक कर रहे, डॉक्टर सविता से पता ही नहीं चल रहा किसी को क्या बात है। Very good. So friends, we'll be speaking on calcium. It's going to be a short talk, but an interesting one for all of you. So why calcium is important at every stage of life? Dr. Tulsi sir mentioned 18 means 18 years. Okay. Whether we require calcium replacement, how much? I'm sure Dr. Ashok Chakraborty sir would elaborate on that when we come to the discussion part. Or 80. So do you still require calcium when you are 80? We will discuss that. And calcium is mighty. Okay? So calcium is a very, very important part of the game. So coming to one of the most important tissues in our body, the bone. It's a living tissue that is the hardest among other connective tissues in the blood, in the body. The solid part remainder consisting of various minerals, especially 76% of calcium and 33% of cellular material. Bone continues to change over the course of lifespan. So it is very dynamic tissue. Coming to the natural history of bone, in childhood there is new bone added faster than the old bone is removed. There is a concept of peak bone mass, or called PBM. Bone resorption exceeds bone formation at certain stages of life, and rapid loss of bone mass after menopause in the next 3 to 6 years. So what is peak bone mass, or PBM? It's the amount of bony tissue present at the end of skeletal maturation. The concept of peak bone mass became familiar about 35 years ago with the frequent use of non-invasive quantitative technology, which you know very well is called DEXA. A 10% increase or about 1 standard deviation in peak bone mass could reduce the risk of fracture by 50% in women after menopause. About 90% of adult bone mass in both sexes is gained in the first 2 decades of life. Peak bone mass is typically achieved by the early to mid-20s. Peak bone mass is a significant predictor of osteoporosis and fracture risk. Post attainment of peak bone mass, there is loss of bone, and lifestyle choices influence 20 to 40% of adult peak bone mass. So it's a concept which all of us should understand. It has been estimated that over 50% of the human skeleton is formed during the teenage or pubertal years. Differences in timing of bone mass accrual are related to gender-specific patterns of pubertal maturation. Peak bone mass and subsequent bone losses are important determinants of osteoporosis later in life, and we'll come to osteoporosis as we go along in the presentation. Ethnic and racial differences in bone mineral densitometry exist, and previous studies have shown that a real bone mineral densitometry, or BMD, measured by DEXA is lower in Indians compared with the Western subjects. So what are the determinants of peak bone mass? Genetics is at the top. Then there is the nutrition, the spelling is wrong, vitamin D, calcium and proteins, and that is why we have three stalwarts on the panel who will elaborate on vitamin D, calcium and proteins. And just to mention that we are going to have a landmark CME on 5th of November, which will be presented by the father of vitamin D in Asia, General Marwa, and will be moderated by none other than two stalwarts from the group, Dr. S.K. Mathur sir and Dr. Sarath Gopalan, who has been instrumental in arranging that landmark CME for all of you. November is going to be a month of landmark CMEs. I will tell you the other CMEs on 5th of November. All 4 CMEs in November are going to be landmark CMEs. Genetics is also influencing the peak bone mass or the strength. And of course, there is an endocrine role from the hormones, and there is a mechanics which is getting involved, and I think we could have Dr. Badwa's input into that, physical activity and body weight. So, what are the genetic determinants in peak bone mass? Number 1, family. Family and twin studies suggest that BMD has a high heritability. What about the gender? In boys, the onset of puberty occurs later than in girls. All of you know it. And the period of accelerated bone growth lasts 4 years, as compared to 3 years in girls. Race. Higher peak bone mass in blacks compared to white individuals could be explained by a bone accrual rate which is higher in black children. Changes in the structure and composition of bone throughout the lifespan. So, there is a periosteal expansion, there is an endocortial apposition, and then there is a periosteal bone formation and endocortial bone resorption. So, these are the processes which are happening in the bone. As we progress from our infant age to childhood to peak bone mass age, which is just about the pubertal age, and the older adults. So there is this story of growth as far as PBM is concerned and aging. Attaining a high peak bone mass in the first 3 decades of life would contribute significantly to prevention of osteoporosis. So what is the concept generally? Osteoporosis is a disease of the elderly. Unfortunately, that is not true. Actually, osteoporosis is determined in childhood. Whether you are going to have osteoporosis or not will be determined by your peak bone mass. And that you acquire when? In your pubertal and pre-pubertal years. So actually, osteoporosis gets determined by calcium deposition and peak bone mass that you get in pubertal and peripubertal years. Thank you, Dr. Pramod. So time and variability of peak bone mass attainment. In adolescent girls, gain in bone mass declines rapidly after menarche with no significant gains within 2 to 4 years post-menarche, at least at the lumbar spine and femoral neck. In adolescent males, the gain in BMD and BMC is particularly high from 13 to 17 years, but remains significant between 17 and 20 years in the lumbar spine BMD and BMC and in mid-femoral shaft BMD, but not in femoral neck BMD. So there are certain variables which we have to be aware. A significant bone mass gain persists in males, but not females. So even after you achieve puberty in males, there is a bone formation which continues for next 3 to 4 years, but is not true in females who reached pubertal stage P5 and grew less than 1 centimeter a year. Most skeletal sites, total bone mineral mass does not significantly increase from the 3rd to the 5th decade. 30 से 50 साल में कोई खास चेंजेस होते नहीं हैं, तो जो होना है 50 साल के बाद वो डिटरमिनेंट होता है 30 साल से पहले ही. So what is the current scenario of nutrient intake? इसके बारे में बात करते हैं कि क्या nutrient intake है और कितने लोग deficient हैं और actually क्या जितना चाहिए वो लोग ले रहे हैं. Research shows that the teenage girls are more likely to become deficient in some nutrients than the general population. Teenage girls are at a greater risk of developing deficiencies in vitamin D and folate. 90% of adolescent girls are young women. They do not achieve recommended dietary intake of calcium on a daily basis. Calcium is not only located in bone but also distributed, as you know. It is a very, very important transcellular element in extracellular and intercellular fluid. And you know it that it is one of the most important minerals for cardiac muscles. आपको पता है. Children who don't get enough calcium are more likely to suffer from bone fractures and may develop osteoporosis as they age. So actually your osteoporosis is determined at a very young age. It is not a disease of the elderly, as we often think. So 1 in 2 women and 1 in 4 men, 25% of men and 50% of women are more prone to have osteoporosis related fractures in their lifetime, the risk of which is determined right in childhood. That is the important thing that I wanted to drive home. So vitamin D status and determinants in Indian, I think more will be knowing from Dr. Sarath as the President of Nutrition Society of India and from Dr. Ashok Chakrabarti sir as to what is the vitamin D status in various states in India, the children and adolescents, and some multi-center study which tell us that the highest proportion of vitamin D insufficiency plus deficiency less than nanomole per liter, you know, the normal levels are from 75 to 250. Okay. In other ways, 30 to 100 nanogram per ml. So you can have the calculation. The worst state that performs on this score is Maharashtra and compares almost with Punjab, Assam and Gujarat, except Tamil Nadu and Chhattisgarh. So you can see the chart. Maharashtra is the state which is the most efficient and is almost comparing with the other states like Gujarat and Punjab. So, what is the calcium intake status in our country? So there is a chart here which you can see on the left hand side is the calorie intake, okay, in men. And then, I'm sorry, this is the average calcium intake adults, the calorie intake chart is the next one. Average calcium intake adult time trends showing a decline in calcium intake over the last 4 decades. So as we have grown up, as we have progressed, GDP has increased, we are becoming a developed country now, and probably the 3rd largest economy in the world. Actually, when it comes to nutrition intake, it's a very, very sorry state of affairs. The calcium intake actually has gone down in the last 4 decades. And as we saw in the previous slides, the most important determinant of osteoporosis in elderly age group is the amount of calcium and peak bone mass in your childhood, pubertal and peripubertal years. That time, the adolescent boys and girls are not very careful about their calcium intake, and you know that very well because you must be having boys and girls in your homes who do not want to take diet which is rich in all these things. They want, all that stuff, the pizzas, the burgers, etc., etc. So there is a profound shortage of calcium intake in the diet. The global estimation of dietary micronutrient inadequacies and some modeling analysis, again it tells us that the calcium intake inadequacy was highest in countries in South Asia, Sub-Saharan Africa and East Asia and the Pacific. So we will be tempted to think that these are all countries which are low down in the economic development panels. But unfortunately, that is not true. Our country is not economically deprived now. As I said, we are going to be the 3rd largest economy, and the state of affairs as far as calcium and the other nutrient intake is concerned, even calorie intake, we'll come to that, is very deficient in our population. So based on estimates of nutrient intake from food, excluding fortification and supplementation, globally more than 5 billion people do not consume enough calcium. And that is the state of affairs when your atta is fortified, when your milk is fortified, your dalia is fortified. Despite that, we are still deficient in calcium intake because there are other sources which we do not take. Okay? So globally more than 5 billion people do not consume enough calcium, and that is about 66% of the entire population. The prevalence was higher for females than for males in most regions for calcium. So, which is understandable that females are more calcium deficient. Understanding these patterns can help us to better identify where nutritional interventions are needed, such as dietary interventions, biofortification, fortification and supplementation. So these are all words which we have to understand: fortification and supplementation. So calcium supplementation is different from calcium fortification. So you are already consuming diets which have to be fortified. So when you add something to that, is called fortification. But when you take it otherwise in forms of pill or something, that is called supplementation. I was talking about this chart when I was talking about the calcium intake chart. The recommended versus the actual food and the nutrition intake in India, both for boys and girls, and it's often said that we are diabetes capital of the world. The reason is that we have a very high carbohydrate intake, etc., etc. But the reality, friends, is that when you calculate the recommended levels of calories for males and females, see the extreme left, the calorie intake chart, the recommendations for males, the recommendations for females, the second one, and third is the actual intake in India. So we are not even taking enough calorie. So it's not only about calcium, it's not only about the other nutrients. Look at the protein intake. So we are deficient in protein intake, we are deficient in calorie intake, we are deficient in iron intake, we are extremely deficient in vitamin D intake, which is a country which is very rich in sunshine, and calcium intake. So everything we are scoring very poorly, and therefore calcium story is a part of the entire story. So global burden of disease study 2019, the LBMD and the fracture is a growing global health burden. We know it. Female had higher burden of disease than males, and the gap widened with age. Global deaths 93.82, and Delhi's number 111.16 attributable to LBMD has increased from 1990 to 2019, which should actually have gone the reverse way, given the economic development. DLYs and death number of LBMD related fractures increased 121% and 148% from 1990 to 2019. So what has happened in the last 4 decades? The calcium intake has gone down. We are actually nutritionally deficient. We are very rich. We consume a very carbohydrate rich diet, but we are calorie deficient. We are protein deficient. And I am sure Dr. Mishmura in the end would shed light on people, because he deals with pregnancy day in and day out, and people have to keep up with their nutritional requirement. It's not only about curing these people with chemo, but also to keep up their daily nutrition up to date, which is not happening, because this is what we are adjusted to, this is what we are tuned to. We are not taking enough of anything. Prevalence of osteoporosis in India, a systematic review and meta-analysis, and one message from the talk, if you can take. I think my purpose of the talk will be over, and that purpose is that please do not think for the repeating for the third time, osteoporosis a disease of the elderly. Osteoporosis is actually a disease which is determined by calcium intake and peak bone mass in your pivotal and pre-pivotal years. Keep that up to date. You do not have the fear of osteoporosis. Prevalence of osteoporosis was significantly higher among females at 26.3% as compared to males at 10.9%. Now you can say, why it is happening? Lot of things. I grew up in a village. I did my 6th in the village. And I know from my part of Haryana, where milk and curd was given only to the male boys. The females were deprived of milk and curd. They were not given that. It was the prerogative of only the male child. One thing. Second thing, the girls stayed indoors. They were supposed to be doing chores at home. They were not supposed to be exposing them to the public. So no sunshine. Except for the time when they were working on the fields. But boys, they were free to play outside, to go out with their friends. Unfortunate aspect, which is now gradually improving, but we are still not there. So prevalence of osteoporosis is nearly 2.5 times in females as compared to males. So what is the differential impact of calcium? So the calcium in bone health, calcium is vital nutrient for everyone, but it plays major role in health. Peak bone mass and subsequent bone losses are important determinants of osteoporosis later in life. Ethnic and racial differences in BMD exist. We understood that blacks are less prone to developing osteoporosis as compared to even us, Asians, and definitely people in Southeast Asia. Some studies have shown that a real BMD measured by DEXA is lower in Indians compared with Western subjects. High prevalence of vitamin D deficiency may also contribute to low BMD. So there is going to be a close correlation between BMD and vitamin D, and more of it on 5th of November, which I have already told you. So you will tune into that. Calcium in childhood. The body's need for calcium is at its highest point between the ages of 9 and 18 years. No duni 18. Not getting enough calcium during this can affect bone strength later in life. Adequate calcium intake during childhood years reduces risk for osteoporosis and fracture later in life. This is the message which is coming again and again. Adequate intake of calcium-rich foods in childhood can lead to higher bone mass in childhood, in adulthood. Diet rich in calcium and vitamin D starting as a young child is one of the best ways to develop strong bones. In adolescence, the bone health it is characterized by an accelerated growth rate associated with rapid muscular skeletal development. During this phase, adolescents manage to gain between 15% and 20% of their final height due to an increase in growth speed equal to 9 cm per year for girls and 10.5 cm per year for boys. During adolescence, approximately 300 mg per day of calcium are deposited, and adolescents incorporate approximately 40% of their bone mass, accumulating by the end of this period 80% of their final bone mass. Approximately 50% of total adult skeletal mass is completed during adolescence. 25% of PBM being acquired during the 2 years around peak growth velocity, that is 12.5 centimeter years for girls and 14 years. Adequate calcium intake during growth is extremely important to reach the optimum peak bone mass. The entire play is pubertal, peripubertal, no duni 18. Adolescent girls, teenage girls are more likely to become deficient in some nutrients than the general population. Teenage girls are at a regular risk of developing deficiencies in vitamin D and folate. 90% of adolescent girls and young women do not achieve the recommended dietary intake of calcium on a daily basis. Can you believe it? 90%. Due to rapid growth, adolescents are at high risk of hypocalcemic features such as tingling, tetany, and seizures. So if you get seizures in a young girl, do not only think of brain issues, think of metabolic issues also. Additional features may include bone pain, muscle weakness, and fractures. Osteoporosis originates during childhood. यही स्लाइड है जिसके लिए सारी की सारी मेहनत की है। Level of bone mass during childhood and adolescence influences fracture risk. Osteoporosis should be viewed as a pediatric health issue. It is a pediatric health issue, and that is why Dr. Ashok Chakraborty sir is on the panel. Peak bone mass is probably a most important population factor. 10% increase in peak bone mass may reduce fracture risk by 50%. 10% बढ़ाइए पीबीएम को और अपने फ्रैक्चर रिस्क को 50% से भी ज्यादा कम कर दीजिए। एज रिलेटेड बोन लॉस, द रेट ऑफ बोन लॉस इंक्रीजेस इन बोथ मैन एंड वीमेन अराउंड 40 to 45 years of age. Bone loss is more pronounced in women because of the hormonal changes, and all of you are well aware of it, the effect of estrogen and progesterone. Bone loss is accelerated to 2 to 5% each year immediately before and for up to 10 years post menopause. These are very, very critical, very, very crucial years in a female's life, because preceding menopause and up to 10 years post menopause, there is an extreme bone loss which can lead to severe complications, and as we have understood, the risk of this actually was not determined now. The risk of this was determined right in childhood. So this is the bone loss which occurs in females at around the age of 40 years. And what is the relationship between aging and calcium? Calcium requirements remain stable until menopause. Okay? In menopausal stage, the bone resorption rate increases and bone mass decreases due to the fall in ovarian estrogen production. Calcium absorption averages 20 to 30%. At this time, this efficiency declines slowly with age. So, जो भी आप कैल्शियम लेते हो, चाहे आप कुछ भी खा रहे हो नहीं खा रहे हो, उसमें से मैक्सिमम जो एब्जॉर्ब होता है वो 30% ही होता है, और ये एफिशिएंसी भी कम होती चली जाती है, especially after menopause when there is a decline in the hormones. By age 65, calcium absorption efficiency is typically 50% below that of adolescent peak absorption. अब जितना मर्जी खा लो, absorb ही नहीं होना है, absorb नहीं होना है, तो दिक्कत होनी है. So aging and calcium deficiency, there is a low calcium intake. One of the reasons, vitamin D deficiency, always there. We are a calcium D deficient nation. Insufficiency or failure of parathyroid gland. Okay, so there is a great correlation between parathyroid, calcium, chronic kidney failure. You know that because of accumulation of phosphates, low blood magnesium levels in cases with severe alcoholism, and diet high in phytates. That is another reason for calcium deficiency. So this is a landmark sentinel paper, vitamin D for the prevention of disease. Last 4-5 slides. An endocrine society clinical practice guideline in children and adolescents aged 1 to 18 years. Empiric vitamin D supplementation of 300 to 2000 units. You can just write this down. These are important recommendations, and we'll go to Dr. Sarath and Dr. Ashok Chakraborty sir, and of course we'll have moderation by Dr. Tulsi sir regarding this. There is a lot of controversy regarding the intake itself. How much vitamin D you require. So in children and adolescent girls 1 से 18 साल 300 से 2000 units. Vitamin D supplementation shown to prevent nutrition rickets and potentially lower the risk of respiratory tract infections. There is a role of vitamin D in immunity. There is a role of vitamin D in bone health. There is a role of vitamin D in converting pre-diabetes to diabetes, and there is a role of vitamin D which you would have understood during the COVID pandemic, when people were there was a trial being done in Max Hospital of giving high doses of vitamin D to prevent the respiratory issues, and people going from low saturation to ventilation, and the study suggested that if you start giving high doses of vitamin D, there was a very good effect of vitamin D. I don't have that paper here, but there is a role of vitamin D in immunity. In the general adult population less than 50 years, aged between 50 and 50 to 74 years. In the general population aged 75 years and older, you need to give a little more vitamin D and you can go up to 900 units. यार पीछे जरा बात मत करो भाई. Vitamin D दो उनको उमेश. बात नहीं करो भाई. Empiric vitamin D supplementation of 800 to 900 units due to the scarcity of natural food sources rich in vitamin D. Empiric supplementation can be achieved through a combination of fortified foods and supplements that contain vitamin D. Panel suggested against routine 25 hydroxy yani vitamin D testing in absence of established indications, and you will know more from General Marwa next Wednesday. It is not recommended. The routine screening of vitamin D is not recommended. You stick to these recommendations and you have done your job. Okay? Current guidelines and position statement for the use of calcium and or vitamin D for bone health. So there are two recommendations from National Osteoporosis Foundation's 2015-2016, which says that calcium is an important nutrient and it is one of the most important determinants of peak bone mass development. And what is the level of recommendation? There is a strong evidence for beneficial effect, particularly during the late childhood and peripubertal years and at a critical period of bone accretion. So calcium should be supplemented or fortified or given. Similarly, National Osteoporosis Foundation 2015, calcium plus vitamin D. Okay, so the risk of fracture, supplementation reduce total and hip fractures by 15% and 30% in community dwelling and institutionalized post. So single point intervention of giving calcium and vitamin D reduces risk by up to 30%. एक और बात है वैसे, अपने वॉशरूम के अंदर एक हैंडल लगवा के भी आप 30% फ्रैक्चर का रिस्क कम कर सकते हो. ये भी एक इंटरेस्टिंग स्टडी है, झूठ नहीं है, क्योंकि बहुत ज्यादा लोग फिसलते हैं बाथरूम में और फ्रैक्चर में फीवर होता है उनको. ठीक है. So there is a recommendations by American Geriatric Society 2014, vitamin D alone, risk of fall and fracture. Clinicians are strongly advised to recommend at least 1,000 unit IU of vitamin D per day plus calcium supplementation to community dwelling and institutionalized older adults to reduce risk of fractures and falls. ये बहुत important चीज है, especially उन लोगों में जो कि institutionalized हैं. A serum 25 hydroxy D level of 75 nanomole, ये वो वाला level है जो 75 से 250 वाला है, यानी कि more than 30 should be the goal to achieve in older adults. Don't aim for 100. You can actually create vitamin D toxicity. ठीक है. और विटामिन डी टॉक्सिसिटी एडल्ट्स के अंदर एक बहुत ही जबरदस्त कॉम्प्लिकेशन करती है और उसको क्या कहते हैं? नॉर्मल प्रेशर हाइड्रोकेफलस. ओके, ये भी एक इशू होता है, उसमें कांस्टेंट हेडेक होता है. तो अगर आप विटामिन डी ठूस रहे हो मरीज के अंदर और हेडेक के साथ आ रहा है तो ब्लड प्रेशर के साथ साथ ये भी देख लो कि विटामिन डी बहुत ज्यादा तो नहीं दे रहे. लास्ट 2-3 स्लाइड बच गई. आउटकम ऑफ कैल्शियम सप्लीमेंटेशन एंड कंप्लायंस. So there is a meta-analysis by Tang et al. 17 trials comprising 52,625 people aged more than 50 years. They were randomized to supplementation with calcium or calcium plus vitamin D. So what was the summary? Calcium monotherapy reduced all fractures by 10%. However, the combined effect of calcium and vitamin D significantly reduced the risk for all fractures. अभी हमने पढ़ा एल्डरली में तो नेशनल ऑस्टियोपोरोसिस फाउंडेशन के रिकमेंडेशंस रिड्यूसेस बाय 30%. कैल्शियम सप्लीमेंटेशन इन एडल्ट्स, मेटा एनालिसिस बाय लियू एट al in 2022, 43 randomized controlled trials, 7,382 participants. So boosting calcium intake in people younger than 35 improved BMD throughout the body, improved BMD at the femoral neck where most hip fractures occur. Okay, so strike when the iron is hot. So this is the place, even less than 35 years. Calcium supplementation produce larger effects in individuals between the ages of 20 and 35. इस टाइम पे भी आप एक्ट कर सकते हो. इफेक्ट ऑफ विटामिन डी, कैल्शियम और कंबाइंड सप्लीमेंटेशन ऑन फॉल प्रिवेंशन, a systematic review and updated network meta-analysis. So what does this say? 11 randomized controlled trials were included in this meta-analysis. 800 to 1000 IU per day. 800 से 1000. यार राजीव बोल मत यार प्लीज. Vitamin D was associated with a significantly lower risk of falls in all subgroups, except in populations with serum 25 hydroxy vitamin D levels more than 50 nanomole and receiving intermittent doses of vitamin D. According to the subgroup analysis, daily administration of 800 से 1000 vitamin D was associated with significant 22% reduction in the risk of falls. So this is the way to go. Real world effectiveness and safety of combined calcium 600 mg and vitamin D 2000 IU for treating vitamin D deficiency. The Dossio trial, observational retrospective multi-center calcium supplementation for at least 24 hafte, treatment with calcium 600 mg and vitamin D 2000 mg for at least 24 hafte is effective and safe, and especially in osteoporosis. After at least 24 weeks of treatment, that serum 25 hydroxy was more than 30. That is what we want, with a change of 15.5 from the baseline, which was statistically significant. Last slide. पहली चीज, is osteoporosis a disease of childhood or adulthood or elderly people? Childhood. All right. The peak bone mass or PBM is attained from the ages of 9 to 18 years or 35 to 50 years. Okay. The risk of osteoporosis in females in India, for whatever reasons, is 1 time, 2 times, 2.5 times, 3 times that of boys. 2.5 times that of boys. Calcium intake or calcium supplementation is only necessary for girls and not for boys. True or false? False. False. Okay. A continuous process of bone turnover is central. डॉक्टर अमीश वोरा हमें बताएंगे मैलिग्नेंसी के बारे में भी और न्यूट्रिशन इंटेक के बारे में भी. आप अपना पानी पी लो सर, आपको बुलाएंगे. A continuous process of bone turnover is central to bone health and strength. Daily intake of calcium in across age group is low in Indian population. The growth years provide an important window of opportunity for building PBM, which is the single most important determinant of fracture risk, of osteoporosis, and for all calcium related issues in boys and girls. Ensuring an adequate intake of calcium and vitamin D can promote lifelong bone health and support overall vitality. Because calcium is not only important and vitamin D is not only important for bone health, it is also important for other things. And always remember that those who are vitamin D deficient, they are very likely to get recurrent URIs. Okay, recurrent URIs. Your immunity is dependent on vitamin D. Calcium deficiency should be always addressed adequately in all patients to make their future strong against bone loss. And with this, friends, I would like to thank you for your attention. We can have the lights on. The good thing today is that I am not supposed to answer much. We have 3 stalwarts. We have Dr. Ashok Chakravarti. We have Dr. Sarat Gopalan, President, Nutrition Society of India, and the Master, Dr. J P S Tulsi sir. And I would like to have a chair here for Dr. Amish Vora. Naresh, can you get a chair for Dr. Amish? Dr. Amish, can you come here, please?
आप भी तो बैठे.
सर मुझे सवाल पूछना
Sir, आइए इधर सर इधर आ जाइए. Actually, nutrition in, we should have a separate talk on nutrition is very है ना? आप मानते हो ना? आप इधर आ जाओ. डॉक्टर सलूजा, आपसे तो हम उम्मीद कर रहे थे सवाल की. Okay. Please sit down. Please sit down. So friends, I would request Dr. Tulsi sir to set the context for the talk that we had. I'm sure you would have had some carry-on points for yourself. Dr. Tulsi sir.
Okay, friends, let us confess. So friends, let's confess that we had a mastery talk by the master. Let us put our hands together for the master. Okay, so let me confess. Come here, Dr. Chauhan, come here. So let me confess, Dr. Chauhan, I didn't know that osteoporosis starts in pubertal or peripubertal age. I thought osteoporosis is because of old age, especially in women, after the age of 50, and in men after the age of 70 years. I learned something new, sir.
Thank you, sir. Thank you. That was the whole point of taking this talk. Apart from giving you a CME post Diwali, because I was not getting any sponsors, and we tried many speakers, nobody was coming, and therefore I requested Sanjeev and Umesh, and they said कि सर speaker नहीं है. मैं जब मेरे पास moderator है, speaker मैं हूँ यार, क्या बात है, कोई चिंता ही नहीं है, ठीक है? And therefore please forgive me, it is not a perfect talk. My favorite topic is diabetes. देखो भैया सीधी सी बात है, मुझे diabetes आती है A to Z, ठीक है? और मैंने डॉक्टर सीएम गुप्ता से बहुत बढ़िया सीखी है diabetes. ठीक है, और मैं डायबिटीज में आप कभी भी बोलोगे खड़ा करोगे मैं आपको बढ़िया टॉक दे दूंगा. ये टॉक मैंने आप लोगों के लिए, ठीक है? दिस इज आम आदमी पार्टी टॉक ऑन कैल्शियम. इफ यू कैन फॉरगिव मी, आई डोंट हैव एनी एलिजियंस टू आम आदमी पार्टी. आई एम ए बीजेपी गाय. खुले में कह रहा हूँ भैया, आई एम बीजेपी सर. कोई बात नहीं सर, कोई फर्क नहीं पड़ता.
So friends, at least three calciums are available, in the sense that we have calcium carbonate, we have calcium citrate, we have CCl. So, which is the best calcium, Dr. Chauhan?
Sir, I have no idea. We would request Dr. Honestly, I have no idea. We would request Dr. Sarath, which is the best calcium?
Let me answer.
Okay, you answer it, sir, please.
Okay. So the best calcium to be absorbed is the calcium carbonate, because elemental calcium is 40% in calcium carbonate as compared to the CCl or the citrate, which has 21 to 24% elemental calcium. So the best absorbed and the best calcium available, calcium carbonate,
Calcium carbonate.
as compared to the calcium citrate and the CCl. Having said that, does acid interfere in the absorption of calcium carbonate or calcium citrate or CCl? Anybody? Dr. Kumar, would you like to answer that? Hold on, I am asking him. Calcium carbonate, is it absorbed in empty stomach or after food? No? So Dr. Mita has answered that.
Okay.
So Dr. Mita, why would that occur? Tell us.
Acid interferes with calcium
As she said correctly,
You should have it with on a full stomach.
as she said correctly, the calcium carbonate needs an acid in the stomach to be absorbed, unlike the calcium, other calcium like citrate and CCl. Okay, let's not dwell about. I'd like to ask my last question to our expert speaker regarding vascular calcifications. Dr. Chauhan, sir?
So this is a very good question, sir. You mean to say the relationship between oral intake of calcium and vascular calcium?
No, sir.
What? क्या
We
question?
are just talking about vascular calcification. Does it occur when you have a dietary calcium or only on supplemental calcium?
There is no relationship, sir.
No, sir.
If there is, please tell me. Please tell me.
So friends, hypercalcemia would only occur with a supplemental calcium, never with a dietary calcium. And what would a hypercalcemia to coronary arteries do? Dr. Chauhan, hypercalcemia in coronary arteries, or forget about coronary arteries, vascular, even the walls. When hypercalcemia is there, by not dietary intake, but because the supplemental calcium, how does it occur? Why does it occur? Can you tell us that? It occurs because, supplemental calcium you take in high doses, especially above, maybe about more than 1500 milligrams, it would not be absorbed. Sorry, it will be absorbed because the oxalate in the stomach, see, will not be there. So probably hypercalcemia occurs here and would get deposited in the vascular calcification occurs here. Because of, if you take high doses of calcium and if you take it empty stomach, this will occur, vascular calcification occurs. Having said that, what are the modalities of choice for diagnosing hypercalcemia, especially in vascular calcemia? As he says correctly, it's probably IRS or yeah. So I think that's about.
Yeah. So we will have input from Dr. Amish because he has to leave about the need to supplement calcium, to fortify calcium in the diet in patients who are being treated for malignancy. Is there a special fear, risk of hypocalcemia in people who are being treated with chemo with malignancy? How do you take care of that?
So I'll answer that, but I wanted to ask you a question. Since you said about diabetes, vitamin D supplementation, does it improve the glycemic index?
So that is a very good question. There are two things here that we have to understand. So there is a concept of impaired glucose tolerance from normoglycemia, and there is a concept of pre-diabetes getting converted to diabetes. Okay? So let's not talk about the prevalence, everyone knows about it. Vitamin D plays a very crucial role in if people are deficient in vitamin D, then normoglycemia to impaired glucose tolerance is the first stage. If you still do not wake up, then this issue progresses from IGT or IFG, impaired fasting or impaired glucose tolerance, to actually diabetes. So and things do not stop there. If you are still deficient, then all the complications of diabetes, especially the complications which are related to kidney, which are related to vessels, which are related to retina, the chances of those complications increases multifold if you are vitamin D deficient. So vitamin D is a very, very important part and parcel of the game. So that is my answer. And always in pre-diabetes, when you are telling your patient to reduce his calorie intake, to go for a physical exercise, please make sure that this patient's vitamin D levels are okay. That's one thing. Second thing, in people who are having issues with statins, we usually think, oh, he's got a muscular issue, he's got a muscular cramp. Two things, always remember, in statin-induced muscular issues, make sure that patient's thyroid status is okay, TSH is okay, and make sure that his vitamin D status is okay. Right? So correct these. Third thing, I would like to have that question extended to Dr. Ashok Chakraborty sir. Children who come with frequent URIs, respiratory infections. Sir, what is the role of vitamin D?
Definitely, doctor. First of all, I must congratulate you for an excellent talk on the basic things, calcium and metabolism and related problem.
Thank you, sir.
It's a kudos to you. It couldn't have been better. You are very right in saying that the vitamin D deficiency is normally associated with different attacks of URI, no doubt about it. Even during COVID, we used to give lots of vitamin D to prevent super complications of that. And as a routine, we have seen that if the levels of vitamin D are less in children, they are more frequently having coughs and colds and different infections for that matter, any body for that matter. It's an immune booster in a way. So adequate amount of calcium, vitamin D, along with that, are a hallmark for a healthy life in a child. And you very rightly said 18 to 80. I would like to say move to tone. The importance of calcium cannot be denied or underestimated throughout the life of an individual. right from the day the baby is conceived. Rather than antenatally also the mother should be taking lots of calcium to supplement to make a storage high, so that the same thing is passed on to the baby in the utero and then postnatal also. So you have really made it a party, even it's news to me, like Dr. Tulsi sir said, कि मेरा concept यही था कि भाई जो osteoporosis है इसे old age problem. I'm enlightened today.
सर मैं इसी एक पॉइंट के लिए ही मैंने ये टॉक लिया.
The beginning of osteoporosis starts in the early life. So adequate amount of calcium, vitamin D is a very important thing to safeguard your post. Thank you so much, doctor.
Your comment on nutrition, I am still waiting for that.
Yes. So it's a very
Before he says, friends, how many of us would know that pubertal or peripubertal osteoporosis occurs? I didn't know. Anybody knew? Nobody knew, sir. Dr. Shireen knew probably. Dr. Swali knew as well.
So, thank you, sir. I think it's very, very interesting. It's very interesting that there are a lot of studies done with vitamin D and cancer. There are two established facts. One, vitamin D supplementation during cancer treatment improves the survival. Unequivocal. But there is not clear association whether it reduces the incidence of cancer. But if you give vitamin D supplementation during treatment
With chemo.
with target, with immuno, whatever, improves survival.
Okay. And we have hard data.
We have very hard data on that. Colon cancer and vitamin D deficiency link is established beyond doubt. The only thing which is not established is if you give daily vitamin D, whether it will reduce the incidence. So that is somewhere the data is lacking, some are positive, some are negative. But the important point is vitamin D has to be given, has to be supplemented if any patient is on treatment for cancer.
Sir, calcium.
So I'll come to calcium, but my second observation in cancer in elderly in Delhi, I don't know about normal, any person who's above 60 and staying in Delhi for last 40 years, their vitamin D is above 40 always. And those who are less than 50, almost 100% of people are deficient in vitamin D. I don't know the reason why, ghee khaya hai ya doodh piya hai, I really don't know, but that is there. And the third last point about calcium, again it's a paradox. Majority of the patient are vitamin D deficient, but जैसे ही cancer diagnosed होता है, every person in the world starts them on calcium supplementation.
Reason?
Multivitamin लेना है, calcium लेना है. Every patient is on calcium supplementation, and that's where the paradox happens that hypocalcemia in cancer is less as compared to vitamin D deficiency. And I strongly believe, as Tulsi sir mentioned, it is because of the supplementation of calcium.
Do you
not
give
because
calcium
of.
to your patients?
Sir, 99% of them are on calcium already.
Vitamin D?
Vitamin D I give to all. Sir.
All.
I give vitamin D in all of my patients.
What is the level you keep?
40 and above, sir. 30 is the cutoff, but even at 30, I give vitamin D. Try to make it at 40. And this thing. So that is something in cancer, vitamin D and calcium.
Thank you very much for your input. You are free to go now. You have to leave.
Just a moment, good after me. So hypercalcemia is a frequent complication in malignancy, especially in metastatic lesions, in multiple myelomas. So hypercalcemia occurs there. Hyper.
Hyper, I will answer that. Yes. Hypercalcemia happens in two main issues. Not every cancer patient will have
Metastatic
hypercalcemia.
cancer, bone
Not every matter.
bone.
Patients who have bone metastasis and patients who have thyroid malignancy are the two people where the calcium metabolism differs. Multiple myeloma, sir, what happens is bone resorption happens.
So,
And in that place, you don't see all patients with hypercalcemia, but yes, those who are diagnosed very late, there you will get hypercalcemia. So any disease where the bone is affected, you get hypercalcemia.
How do you treat such like patients?
So,
Hypercalcemia?
hypercalcemia, there are two types of hypercalcemia. One is symptomatic hypercalcemia, second is asymptomatic hypercalcemia. In symptomatic hypercalcemia, calcitonin spray also comes, subcutaneous and IV also comes, that reduces. But the most important are the two main, one is rank ligand inhibitor, that is called as denosumab. Denosumab is a monoclonal antibody, and in fact, again, thanks you reminded, there is a very nice guidelines for osteoporosis treatment. Invariably, every patient is on teriparatide.
Absolutely. Friends, this is so important.
And teriparatide has got no studies in cancer patients. So please, any of your relatives, any of your known to is on cancer treatment, and if it's on teriparatide, stop that and switch to denosumab. Denosumab is a rank ligand inhibitor, as I said, and it prevents the bone resorption. And as a result, osteoclastic activity reduces, osteoclastic increases, and calcium metabolism.
Thank you, sir. Thank you.
Thank you, sir. So I'm happy that Tulsi sir for the first time said good answer.
Thank you. Thank you, Dr. Anish. I appreciate your presence. I would request Dr. Sarat Gopalan to give his input on this very important topic. I think nutrition, Dr. Sarat Gopalan se बढ़ के बंदा नहीं मिल सकता. Right here you have the President of Nutrition Society of India, Dr. Sarat Gopalan. Please.
Thank you, Dr. Sushil. Just a point, a teaser to start with. You said 18 to 80, calcium, might or mighty. Is it 18 months or 18 years?
18 years to 80 years.
18 days.
So you've forgotten pediatrics. Please remember
That is why I
pediatrics.
have two pediatricians here.
It's a huge problem in pediatrics. Please remember, and I'll get Dr. Chakravarti's views also on this. The point is, what we need to remember is, vitamin D and calcium go together. Calcium alone or vitamin D alone is useless. You'll hear this abundantly next week when Dr. Malwa speaks, who's the world authority on vitamin D in Asia, and I'll be there also in the conference. He's an authority on vitamin D. He'll tell you why vitamin D and calcium, irrespective of the age, have to be together. Pediatrics, adult or adolescents, doesn't matter. Elderly, every age, vitamin D and calcium have to go together. It's very, very important because both complement each other. If you just use one, it doesn't serve the purpose because there will be a lacuna which you will face not immediately but 3 months or 4 months later.
Drive home the point. Drive home the point.
Yeah. The point is both have to be together. So that's the important issue. So vitamin D and calcium go together. Calcium supplementation is important at every age. But in the first year of life, as Dr. Chakravarti knows, vitamin D in the first year of life is a universal policy. And he will comment about it. I will request him to comment. Next week, you'll hear more from
I don't know. I need your comment on one thing.
Yes.
In the rural India,
Yes.
farmers who work for about 8 hours, 7 hours in sunlight, do they still require vitamin D supplement?
Absolutely. That's exactly what Dr. Malwa will tell you.
Okay, that is
Our
very
vitamin D
That
requirements
is
in
very
India, in South Asia, are much more than the vitamin D requirements in Europe and US. And the reasons why they are more important, he'll tell you next.
So 5th
It's
November,
much more.
friends, you can miss any CME from Physicians Forum. Do not miss the CME on 5th of November. It's going to be one of the most important CMEs of your life, I'm telling you. A guy who has more than 250 publications on vitamin D, the father of vitamin D in Asia, and has done some fantastic work, original work on vitamin D. And the person who has arranged this CME for all of you guys is sitting right here. Okay. Dr. Chakravarti, I want your input and then we'll wind it up, sir.
I have a last question.
Yeah, sure.
Dr. Shah very rightly said that the calcium and vitamin D go hand in hand. There is a synergistic action of both. One has the absorption of the other way around. So that's the reason Government of India and IAP both together decided to start a protocol that right from day one of the infant, we started adding or supplementing vitamin D to the body. It was not there about 10 years back, but over the time we have realized that the beginning of osteoporosis starts in the early life. Why not to give adequate amount of vitamin D, which will help in absorption of calcium, which is going from the mother's milk. So,
My last question to the two pediatrician, esteemed pediatrician, learned pediatrician here would be regarding the GACI. You talk about the GACI.
What is GACI, sir? नहीं मालूम सर, बता दो ना.
Okay, it's generalized arterial calcification of infancy. It's a genetic variant we see, which is because of the ENPP1 gene variant. So this occurs primarily in the first 6 months of infancy, and the rate is about 1 in 2 lakhs. So this is an arterial calcification of infancy. Thank you, sir. Many questions?
Yes, ma'am.
Audience.
Dr. Chakravarti ma'am. Rajni Chakravarti
So
ma'am.
you said genetics plays a very important role in this. Now, is it gender-based or, I mean, in the males also the risk is...
Both in males and females, ma'am.
Okay.
Genetics plays a role.
Okay. And second thing you said after 35, like till 2 years pre-menopausal, do you think one needs calcium? Because it was required mainly during...
Throughout, 18 or 18, you require calcium intake, ma'am. I wanted to drive home the point that you need calcium and vitamin D intake throughout your life.
So does it dose increase or decrease in
So between 35 to 50 years, as you said, I kept it around 600 units, but as you grow more than 75 years, it's about 900 units. Because the absorption decreases. This is the problem. Despite vitamin D, your calcium absorption is decreasing by more than 50% as you age. Therefore, you require high doses of vitamin D.
Okay, a person is taking calcium with either 250 units of vitamin D3 or 500 units, and we are still giving weekly 60 lakhs. So does the dose has to anything to do with...
Weekly 6 lakhs you mean?
Yeah, weekly 6 lakhs we are giving, and the person is also taking calcium with 500 units of vitamin D.
So make sure that you do vitamin D level 30 at 6 months. Never produce hypertoxicity.
Yes.
That's the problem. Right? And normal pressure hydrocephalus is one of the complications of vitamin D. Any other question?
Sir, should it be taken with milk or some fat or anti-stomach?
Vitamin. The way of taking it. The way of taking calcium and vitamin D. Please address. अरे आप बताओ यार, President, Nutrition Society of India.
Way of taking calcium and vitamin D in children or adults?
Adults में क्या लेते हैं? खाली पेट की खाने के बाद.
Yeah, with fat or some milk.
You can take it either way, either before or after.
Where is the absorption better?
Doesn't matter.
When is the absorption better?
Doesn't make that much of a difference. Huge.
It doesn't make much of a difference whether you take it empty stomach or the same with the mind.
Unlike iron, where it's very different, in calcium it's not huge difference.
So, how much calcium to be given in infants and children?
Infants and children, what is the...
I'll tell you. Up to 4 years, it's about 700 milligrams which you need. Between 4 years to about 11 to 12 years, you can go up to 1000 milligrams per day, and after that is 1300 milligrams per day. These are the Indian and global requirements, both. But the point is, how many of our children are taking it that much? That's the point. We have seen several, we have done field studies in adult population in nutrition, where women have consumed as low as 300 milligrams per day and are still managing field work in the fields. That's sad, because at some point in time it will give way. Where their basic requirement is 1000 milligrams, they are taking 300 milligrams, 1/3 of their requirement. But coming to children, as I told you, it's 700 milligrams up to 3 to 4 years. After that, it's about 1000 milligrams, After 10 to 11 years, the pre-pubertal age group and throughout puberty, it's 1300 milligrams.
सर के बाद डॉक्टर कादर को डॉक्टर कादर का क्वेश्चन
So I just wanted to answer Dr. Kiran for the last question. Initially, now nanotechnology has come. Before that, the tablet had to be given. We told the patient, please paratha या घी या मक्खन खा के खाना, तभी absorption होगा. But now with the nanotechnology,
There is no relationship between that.
No relation.
Earlier, you say vitamin is a
Because it's a fractional vitamin.
So we used to give it along with fatty.
Exactly, because
but not anymore.
No, because
Being
of the
a nanotechnology,
exactly.
it gets commercialized.
It gets
So there's no harm.
absorption is good, irrespective of the food we take.
Irrespective of the food.
Yeah.
All the tablets are with nanotechnology.
डॉक्टर गुरमीत मैम
Same thing.
another master डॉक्टर कादर सर डॉक्टर कादर
Sir, such a nice talk and wonderful interaction, sir. So about vitamin D, she has very well explained that nanotechnology has made it.
Sir,
more.
Dr. Kalra, not a question but some words of wisdom from you.
Sir.
Let us have some words of wisdom from you.
Okay, sir. At times we find that calcium levels and vitamin D, they don't go hand in hand. You have vitamin D low and calcium either normal or higher. So what to do, Dr. Tulsi sir?
You said normal calcium with low vitamin D?
Vitamin D low and calcium high, or say high normal.
No. What do you mean by high normal? Is it hypercalcemia?
10.6.
10.6 is fine. So 9 to 10.5 is a normal calcium level.
So it's not
We know
matching.
what to do. We know it's present in two forms, ionic as well as the albumin form. So what are you talking about? Are you talking about ionic calcium or the albumin form?
We usually get a report, it's a total calcium.
He says
10.6. So what do you expect? What do you expect in a 10.6 calcium?
10.6 is fine.
Okay.
10.6 is fine. So what if it be low, you said?
Yeah.
So
Say 9.
why would that occur? The pediatricians are here.
So anything which is less than 30 is known as deficiency.
Yeah.
More than that is sufficiency, between 30 to 60. More than that is over, and above 100 is toxicity.
Each question. No. Each question is different.
When it is diversified, sir, calcium level is high and vitamin D low.
Sir, Dr. Kalra sir.
No.
Just a minute. Master, just a minute. Do you know the answer?
Sir, it's a speculation. It's a speculation. Nobody knows the answer.
It's a hypothetical question.
No.
It happens.
We see, yeah.
All right.
You must have seen, sir. I say you must have
Do
seen.
you have an explanation for this?
Yes.
Sir, I think we can discuss it in the next CME.
Right, sir.
Dr. Kalra sir, I assure you, you will not have a better CME.
अगले जन्म में फिर जन्म लेंगे हम.
Thank you, sir. Thank you. Sir, एक फोटो लेनी है. एक फोटो लेनी है. डॉक्टर सक्सेना सर प्लीज आ जाइए.
Only the youngsters of the forum are allowed.
No, everyone.
आप आ जाओ पहले.